I'm here to talk about ACL surgery outcomes and what happens when a patient has their ACL fixed. Lately, when we've looked at ACL surgery outcomes and how the patients do down the road, we've come to find out that not all patients are doing maybe as well as we would have thought they would have. We've tried to correlate that back to the surgical technique and looked at the way we've performed surgery over the last 30 years in ACL reconstruction. We've seen changes in terms of the way we actually do the technique, and we're trying to focus on a more anatomic approach that'll help us improve the results of ACL surgery. Along the same lines, we definitely need better outcomes data to tell us what we're doing in the operating room improves patient outcome down the road. So we have a lot of room for improvement in doing ACL surgery. While we do fairly well with most of our patients, I think our outcome data clearly tells us there's room for improvement. When we look at how patients do after ACL surgery and their ability to return to their previous level sport and participate at the same level, same amount of time, same amount of weekends, our data tells us that maybe only about 60 to 80% of those patients are able to do that if we look critically at their outcome after an ACL injury. Unfortunately, in our profession, we've taken it to the point that our athletes seem to think that 100% of patients after ACL surgery go back to their previous level of performance and their sport. But now we have critical data that tells us only about 60 to 80% of people are doing that, and that's 9 to 12 months after ACL surgery, not 4 to 6 months after ACL surgery. So again, when we look at our outcomes and looking critically at our high performance athletes that have this very common operation in 2011, we have room for improvement in terms of this category. So when we talk about long-term outcome of patients that have ACL surgery, I think we have to really define what we mean by long-term outcome. So first of all, we need to define our subgroup. So our subgroup of patients that have this surgery is probably the age of 14 to 22. So these are high school collegiate kids that, whether they're playing collegiate sports, high school sports, or they're the weekend warrior, they tear their ACL. So they have their ACL surgery. What does this group's knee look like 10 years down the road? Now remember, so 10 years later, they're in the age group of 24 to say 35. So these are young people that have had surgery 10 years ago. What we have found when we look at them critically, these patients are not doing so well. The majority of them have had to drastically change their knee quality of life. So if they want to be a daily jogger, if they want to play tennis every day, if they want to play on an adult soccer league, the reason they've had to change that is because they've developed osteoarthritic changes in their knee. When we look radiographically at that knee, so we take a plain radiograph and look at that knee that had ACL surgery 10 years ago, over 50% of them have radiographic evidence of osteoarthritis. There's a lot of theories about why that happens, but we really do not have the exact answer that says if you do this, you're not going to get osteoarthritis 10 years from now. The concern for us, obviously, is this is a very young age group that now has osteoarthritis, and all of us understand no one has the cure for osteoarthritis. So when we look at patients that have ACL surgery, what can we tell them when they're in the office about how am I going to do after surgery? Most importantly, am I going to have surgery again? Because that's the first thing the athlete or the mom or dad want to know when their child's in your office. And Dr. Johnson, what about my other knee? Is my other knee at risk? Or a common question is, what about the ACL reconstruction? So Dr. Johnson, when you fix my ACL, it can never get injured again, right? That's a question they ask. So when we look critically at that 14 to 18-year-old age group, so now we're talking about kids that participate in level 1 or ACL-dependent sports year-round. So they're in an indoor league, they're in an outdoor league, they're playing sports year-round. What we have found is that particularly in the first 2 years, so 2 years from the index operation, up to 20% of patients are even having surgery on the same knee, and whether that be a failed ACL reconstruction or a meniscal tear, or in some studies it has been shown that they're at an increased risk for tearing their opposite knee, so their opposite knee's ACL, their good knee if you will, up to about 10% of patients. So clearly when we look at this subgroup in our office, 14 to 18 years old that are having primary ACL surgery for the first time, up to 20% of those patients are going to have further surgery in the next 2 years. Something very concerning for us and obviously concerning for the parents that we see. So when we look at the actual technical issue of ACL surgery, a lot has changed over the last 30 to 40 years. We started long ago with fairly non-anatomic techniques, and while we made the knee relatively stable, we found a pretty poor results when we look at our athletes getting back on the field, development of osteoarthritis, and just a bad knee. So a lot has changed in the last 30 to 40 years in ACL surgery. Clearly, in the last 20 years, with our surgical techniques, we've done a much better job of making the knee stable so the athlete can get back on the field. Now, they might not get back on the field at the same level they were before, but today, in 2011, we do a fairly good job of getting back on the field. If we try to look more critical, so in other words, really dive into the anatomy of the ACL, what we have learned in the last 5 years is the ACL is a complicated structure. And with our current surgical techniques, we have no way to perfectly reproduce what Mother Nature gave you, is the bottom line. But we're doing a better job today than we were just 5 years ago. So the focus today in 2011 on ACL surgery is to try to be as anatomic as possible with your reconstruction. And what we have found is that where the ACL attaches on the femur and on the tibia, the footprint, if you will, the bony anatomic landmarks for your ACL to attach is much larger than the actual ligament itself. So the ligament, when it goes from the femur to the tibia, is relatively small, but the footprint on the femur and the tibia is much larger. So for us, we have no way to come up with a graft alternative to reproduce that native anatomy. An attempt to do that is with anatomic single bundle or double bundle ACL surgery. There's studies currently going on to try to help us understand what surgical technique may produce a better outcome. Most importantly, is there some type of surgery that hopefully we don't get osteoarthritis 10 years down the road in 50% of our patients? I think the most important thing though for orthopedic surgeon is what we have learned in shoulder surgery, knee surgery, everything we've learned about orthopedic surgery in the last 50 years is we have to try to reproduce what Mother Nature gave us as best as possible. We're finally starting to do that in the knee with ACL surgery in the last 5 years. I think the take-home messages for surgeons performing ACL reconstruction today are the discussion you have with the athlete and the parents in the office is very important. I think in the current society we live in, where everybody is on the internet, watches ESPN. Everybody is under sort of the impression that I tore my ACL, I'm going to have my ACL fixed, I'm going to play in 4 months, and everything's fine. Unfortunately, it's never quite like that. And the media, ESPN, we don't hear about the true stories that happen with our patients in the office. So I think the take-home message for ACL surgeon is you have to educate your athletes, your parents about what this injury means. What does this mean when I have my ACL reconstructed? Am I going to get osteoarthritis? Yeah, there's a chance of that. Is there things I can do to prevent that? Yeah, keep your weight down, stay active. Hopefully you don't have meniscus and articular cartilage problems at the time of your index operations. What about, can I re-tear my ACL? Can I tear my ACL on my good knee by going back to ACL-dependent sports? I think we need to be upfront and be honest with our patients and tell them, yes, you can re-tear your ACL that we just fixed. Yes, you can re-injure your ACL on your good knee. And if you're young and you're particularly a female soccer player, then your chance of that may be up to 20%. I can tell you that 5 years ago, I totally changed the way I personally perform ACL surgery. That was very hard to do. It took a lot of time in the operating room. It got me out of my comfort zone as an ACL surgeon. But the bottom line is I felt that anatomic ACL repair is better for my patients than doing non-anatomic ACL surgery. So we as surgeons have to have the ability to change what we do based on the information we learn and not be stuck in our old ways of taking care of patients if we find there's a better alternative to doing ACL surgery. And I clearly think anatomic ACL repair, whether you do it a single bundle or a double bundle, is clearly the way to do this today in 2011. And we hope that 10 years from now that our incidence of osteoarthritis will be decreased in this patient subgroup by doing a more anatomic ACL repair.